You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about atrioventricular septal defects. We'll talk about the types of AVSDs, their physiology and presentation, and when to intervene. Let's start with the types. If you have both an ASD and a VSD, then that is a complete AV septal defect. These have a single AV valve. A partial AV septal defect has a primum ASD defect and a cleft anterior mitral leaflet. In between these two ends of the spectrum, you have several possibilities. If you add a small ventricular septal defect to a partial atrioventricular septal defect, then you get a transitional AV septal defect. The small inlet VSD is mostly obliterated by chordal attachments to the septum. If you add a large ventricular septal defect to a partial atrioventricular septal defect, then you get an intermediate atrioventricular septal defect. It will have a common atrioventricular valve annulus separated by a tongue of tissue into two orifices. Transitional atrioventricular septal defect acts like partial atrioventricular septal defect in physiology, while intermediate atrioventricular septal defect acts like complete atrioventricular septal defect in physiology. Recall that the septal leaflet of the tricuspid valve is always lower than the anterior leaflet of the mitral valve. They do not insert into the atrioventricular septum at the same level. There is an offset. If the atrioventricular septum is missing, there will be a hole in the anterior mitral valve leaflet, also known as cleft mitral valve, and the mitral valve leaflets will now find itself lowered to the same level as the tricuspid valve. So if you see dropout of the inferior part of the atrial septum, along with the mitral valve on the same level as the tricuspid valve, suspect partial AV septal defect, which is the combination of primum ASD plus missing AV septum and thus cleft mitral valve. The atrioventricular node is typically displaced inferiorly in AVSD and is associated with relative hypoplasia of the left anterior fascicle. Late onset complete heart block, as late as 15 years after surgery, has been noted after surgery in patients operated on for AVSD who were discharged from the hospital in normal conduction, although it is more commonly seen in patients who had transient post-operatively heart block. That's why regular ECG is important to evaluate for conduction abnormalities in AVSD. The other consequence of lower level of the mitral valve in partial AV septal defect is that you get LVOT obstruction from an elongated outflow tract and accessory chordal tissue. In a normal heart, the apex to aortic valve and apex to mitral valve distance is the same. In partial AV septal defect, the mitral valve is lowered, so the LV outflow tract becomes longer. So whenever you identify primum ASD, you need to look for LVOT obstruction. The 2018 Congenital Heart Guidelines give a special mention to intervening on LVOT obstruction in AVSD. Operation for discrete LVOT obstruction in adults with atrioventricular septal defect is reasonable with a maximum gradient of 50 millimeters of mercury or greater, a lesser gradient if heart failure symptoms are present, or if concomitant moderate to severe mitral or aortic regurgitation are present. That is a Class 2A recommendation. 50% of Down syndrome trisomy 21 patients have congenital heart disease, the most common being AVSD, atrioventricular septal defect, with tetralogy of Fallot. Conversely, the most common genetic syndrome in patients with AVSD is Down syndrome. Normally, AVSD should only have left to right shunting, as long as the VSD is restrictive, meaning the VSD is small enough that it restricts both flow and pressure to the right heart and does not damage the pulmonary vascular bed. However, if the VSD is large, it can cause RV volume and pressure overload and damage the pulmonary vascular bed and cause irreversible pulmonary hypertension and increase pulmonary vascular resistance, triggering right to left shunting and Eisenmenger syndrome. Now let's talk about when to intervene. According to the 2018 Congenital Heart Disease Guidelines, surgery for primary repair of atrioventricular septal defect or closure of residual shunts in adults with repaired atrioventricular septal defect is recommended when there is a net left to right shunt with a QP to QS ratio of at least 1.5 to 1. a PA systolic pressure less than 50% systemic, and pulmonary vascular resistance less than 1/3 systemic. That's a class 1 recommendation. So these are the same parameters as with for ASD and VSD. If pulmonary artery systolic pressure exceeds 50% of systemic pressure and pulmonary vascular resistance exceeds 1/3 of systemic resistance, the guidelines still allow for VSD to be closed, but just more reluctantly so, as a Class 2B recommendation. And that's the same policy as for ASDs, VSDs, and PDAs. They say surgery for primary repair of atrioventricular septal defect or closure of residual shunts in adults with repaired atrioventricular septal defect may be considered in the presence of a net left to right shunt with a QP-to-QS ratio of at least 1.5 to 1. If pulmonary artery systolic pressure is 50% or more systemic, and or pulmonary vascular resistance is greater than 1/3 systemic. That's a Class 2B recommendation. But they put a hard stop in not allowing AVSD closure if pulmonary artery systolic pressure exceeds 2/3 of systemic pressure or pulmonary vascular resistance exceeds 2/3 of systemic resistance. This is the same policy as for ASDs, VSDs, and PDAs. They say surgery for primary repair of atrioventricular septal defect or closure of residual shunts in adults with repaired atrioventricular septal defect should not be performed with pulmonary artery systolic pressure greater than 2/3 systemic, pulmonary vascular resistance greater than 2/3 systemic, or a net right to left shunt. Class 3 harm. Most adults with atrioventricular septal defect will have had surgical repair as children. If those with complete atrioventricular septal defect with large ASD and VSD are not repaired early in life, typically less than 6 months of age, irreversible pulmonary vascular disease usually develops, resulting in Eisenmenger physiology, precluding complete repair. For those who underwent a surgical repair, long-term follow-up is required to monitor for left atrioventricular valve regurgitation and stenosis, left ventricular outflow tract obstruction attributable to the abnormal shape of the LVOT, and tachyarrhythmias and bradyarrhythmias. Left atrioventricular valve regurgitation is the most common reason for later surgical reintervention. It is not uncommon for AVSD patients to develop MR post-AVSD surgery and eventually need either mitral valve repair or replacement. Surgery for severe left atrioventricular valve regurgitation is recommended per GDMT indications for mitral regurgitation. That's a Class 1 recommendation. That's a summary of atrioventricular septal defects.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.